All right, we've made it through the meat of the course. Hopefully, these last two modules, you've learned a lot about the neuroanatomy and the neurophysiology that creates long-standing central sensitization. You have a newfound appreciation of the interaction between the nervous system and the immune system. You understand non-neuronal immune polarization. You understand the balance between pro-sensitization and pro-resolution chemistry. You understand and know those mediators and what their effects are in terms of either sensitization or resolution. And the next two modules hopefully will be a little more enjoyable for you. And this module, module 3, we're going to put it all together in sort of a storytelling way. And the example we're going to use is the lumbar disc. We're all familiar with discogenic nociception and chronic low back pain. So it'll just help us kind of put all the pieces together and hopefully give you even greater appreciation for the role of neuroimmunochemistry in the development of chronic back pain. So as we know, like in chronic knee pain, imaging not always very useful, as the degree of tissue damage or degeneration doesn't correlate well with the level of pain. Also, there's a very high false positive rate with high frequency of degenerative findings in asymptomatic individuals. This does not mean, however, that it is non-nociceptive pain. We can't visualize nociception. It is molecular, it's chemistry, and short of the TSPO measuring and visualizing neuroinflammation in the central nervous system, we have nothing in the peripheral nervous system that really allows us to visualize ongoing neuroinflammation. This is why we can't really extrapolate or come to many conclusions based solely off of imaging. But again, this does not mean that there's not a nociceptive driver in chronic back pain. And let's dive into that. So here was a big meta-analysis of 14 high-quality case control studies that included over 3,000 individuals. Demonstrates that many degenerative spine findings have a higher prevalence in individuals 50 years of age or younger with self-reported low back pain compared with asymptomatic individuals. Their study found that in the adult population of 50 years or younger, annular fissures, high-intensity zones, and modic type 2 or 3 changes had no association with low back pain. However, let's look at the graph on the right. We do see that in symptomatic individuals, much higher prevalence of disc prolapse, disc extrusion, disc degeneration, and modic 1 changes. So while, yes, there's still a very high false positive rate, there does seem to be a difference in the overall prevalence of these findings in those people that do have symptomatic low back pain. So we can't just ignore the imaging, but certainly it doesn't tell us the whole story. So let's look at a comparative study to evaluate disc degeneration on MRI in patients with chronic low back pain versus asymptomatic individuals. So another study looking at those with pain versus those that don't have pain. So the present study aimed to investigate the association of disc degeneration with low back pain and the effect of aging on disc degeneration in low back versus asymptomatic patients. Result, a statistically significant difference in degeneration at the L4-5, L5-S1 disc levels between these two groups, and contiguous disc involvement was more in the low back pain patients. The subgroups of Group A showed no statistically significant difference. Age showed a strong positive correlations at all lumbar levels with Furfman grading in Group A. There was a weak positive correlation between age and Furfman grading in the controls at the L4-5 level only. Conclusion was significantly higher Furman grading on MRI was found at the L4 and L5-S1 levels in symptomatic patients, suggesting higher involvement of these levels. Yes, progressive degeneration is seen with aging, but in patients with low back pain, it is significantly accelerated, just showing, there is probably a higher prevalence of degeneration in symptomatic patients, as well as an increase in an accelerated rate of degeneration in symptomatic patients. Again, it doesn't help us when we're looking at an MRI. We've got one person in front of us. It doesn't really help us in terms of deciding whether there's relevance to that image, but just showing globally that it does seem to be a difference in MRIs between those with symptoms and those without symptoms. So what exactly is going on? Well, if it's not necessarily related solely to structural, then what is it? So what's the difference? Why are some disc issues painful and others are not? There is a thought process out there that is nothing to do with the peripheral driver, that it's all about nocebo and fear and psychosocial issues. While these are, of course, important factors, it's not the whole truth. What we see to be very relevant, again, is the neuroimmunochemistry, meaning whether that person is expressing an ongoing neuroinflammatory communication that is nociceptive and will drive pain versus more of a pro-resolution chemistry. So if you have a patient with a pro-inflammatory chemistry, meaning low-grade systemic neuroinflammation, and an inflammatory cascade kicks off within the contained microenvironment of a non-herniated disc, you can appreciate the difficulty of bringing that to resolution. There's no exercise, no amount of pain neuroscience education or medical intervention outside of a disc excision that can bring that process to a halt. So let's look at chemistry. These are 3 separate studies looking at non-painful versus painful disc and seeing, is there perhaps a difference in chemistry or ongoing nociception that's driving this patient into pain. So study 1, a study comparing painful surgical disc versus asymptomatic post-mortem degenerated disc, suggests that expression levels of matrix metalloproteinase 10, nerve growth factor, and substance P are significantly higher in painful degenerated disc than in pain-free degenerated disc, and that the pathways involved in matrix degradation in painful degenerated disc are different from those in pain-free degenerated disc, again speaking to a difference in chemistry. Second study, the findings of the present clinical study are the results of the first examination of circulating cytokine levels in degenerative disc disease and spinal stenosis and provide evidence for a more extensive role of IL-6 in disc diseases where patients with degenerative disc disease or spinal stenosis have higher serum cytokine levels than those with disc herniation or control subjects. These findings suggest that low back pain subjects have low-grade systemic inflammation. Again, another clue that the difference in painful versus non-painful is in the chemistry. Third study, overall our findings suggest that systemic inflammatory profiles vary between disc herniation subjects with acute or chronic pain. When evaluating disc herniation severity versus cytokines in acute subjects, we didn't observe the same relationship as seen in all disc herniation subjects. Our findings show that systemic inflammatory profiles have stronger association with disc herniation in chronic subjects compared to acute conditions, meaning that it is chronic neuroinflammation that creates chronic pain patients. Inefficient healing or inefficient resolution or prolonged inflammation can drive chronic dysfunction, and therefore studies of inflammation in this patient population may shed important insight into the disease progression and recovery of disc herniation and related back pain. So there's 3 conclusions showing that chemistry and ongoing inflammation may be the answer between a painful versus non-painful situation. This is a big study here where, in terms of its relevance, inflammatory serum protein profiling of patients with lumbar radicular pain 1 year after disc herniation. So what they did here is they took two groups of people, both with disc herniations. One group, their pain resolved, and the second group developed chronic radicular pain. For each patient, an inflammation score that is weighted average of the 41 protein levels was constructed. Notably, the two groups were completely separated. All high pain patients had positive inflammation scores, whereas all low pain patients had negative scores. Thus, an inflammatory fingerprint in the serum of the patients with persistent lumbar radicular pain after disc herniation was demonstrated. The data showed a clear increase in cytokine levels in the patients that developed chronic pain. So that is very conclusive evidence, and hence at the fact that it is the ongoing inflammatory profile that drives patients to chronic symptoms. Those with negative inflammation scores, every single one of them had resolution of their symptoms at 1 year. We've looked at this study once before. We're looking at that measurement of TSPO, which is a glial activation marker. It's a way to visualize neuroinflammation. Their observations suggest that thalamic neuroinflammatory signal is a reproducible and discriminating feature for chronic low back pain, further supporting a role for glial activation in human chronic low back pain and the exploration of neuroinflammation as a therapeutic target for chronic pain, meaning that it is ongoing neuroinflammation, here measured in the supraspinal regions in the brain, showing ongoing neuroinflammation as a distinguishing feature for chronic low back pain. Another study we touched on earlier, neuroimmune signatures in chronic low back pain subtypes. So they showed that patients with different chronic pain conditions, such as chronic low back pain, fibromyalgia, migraine, and Gulf War illness, demonstrated elevated brain and or spinal cord levels of TSPO, suggesting that neuroinflammation might be a pervasive phenomenon observable across multiple etiologically heterogeneous pain disorders. Interestingly, the spatial distribution of this neuroinflammatory signal appears to exhibit a degree of specificity with respect to the involvement of the somatosensory cortex, suggesting that different pain conditions may exhibit distinct neuroinflammatory signature. Our findings support the existence of neuroinflammatory signatures that are accompanied by neurophysiological changes and correlate with clinical presentation, in particular with the degree of nociplastic pain in chronic pain patients. Again, proof and evidence that it is the ongoing neuroinflammatory process that drives chronic pain, and even more surprisingly, that it seems to be very specific in its location within the somatosensory cortex, depending on the type of pain syndrome that we're talking about. This is just a little thought process here where we're looking at, is it an ongoing inflammatory communication, or is this more of microinstability driving this chronic low back pain? So a combination of the increased innervation of the nucleus pulposus and increased production of pro-inflammatory mediators suggests that the mechanism for discogenic low back pain may be the induction of hyperalgesia in the newly innervated degenerating nucleus pulposus. Both IL-8 and the prostaglandin PG2 are known to induce hyperalgesia. So what they looked at, we know that micro movement still occurs between the vertebral bodies anteriorly in the presence of a fusion surgery. Weatherly, Prickett, and O'Brien published a series in which discogenic pain persisted postoperatively despite a solid fusion. These patients were then cured by the addition of disc excision and fusion. Butterman et al. Confirmed these findings and correlated the failure of posterior fusion alone with the presence of modic changes, which are, of course, inflammatory bone marrow changes adjacent to the level of degenerated disc at the symptomatic level. So When micro movement is sufficient to cause pain, which in turn responds to excision and fusion of the disc, the mechanism of the generation of the pain cannot be attributed to instability, but is consistent with hyperalgesia induced in an innervated nucleus pulposus by inflammatory mediators, meaning it is ongoing chemistry. It is nociceptive. It is the pro-inflammatory chemical mediators present within that disc that drive chronic back pain in these situations. So hopefully that paints a very clear picture, or at least is strongly persuasive in that ongoing neuroinflammation, neuroimmunochemistry maybe gives us a lot of answers into why patients may develop chronic low back pain. So multiple studies have shown a significant correlation of pro-inflammatory cytokine levels and pain intensity levels. Higher pro-inflammatory cytokine levels in painful versus non-painful neuropathies, and higher levels of pro-inflammatory cytokines in severe sciatica versus controls or mild sciatica patients. Contrary to that, studies show higher levels of pro-resolution cytokines in patients with mild or no low back pain, higher levels in patients with painless neuropathy, and higher levels in mild versus severe sciatica. Levels of IL-10, which is the pro-resolution cytokine, also negatively correlate to the Oswestry Disability Index, meaning higher levels of IL-10, less disability, and vice versa. This shows an imbalance in pro-inflammatory and pro-resolution chemistry as a likely driver of symptom severity and the risk of developing chronic pain. So let's walk through what this might look like. So we touched on briefly this newly discovered mechanically sensitive ion channel, likely very relevant in a disc model as the cells of the intervertebral disc express this piezo 1 channel. It is a newly discovered mechanically sensitive ion channel. The piezo 1 channel opens in response to mechanical stimuli, transducing mechanical signals into an inflammatory cascade in the cell, leading to inflammation. Piezo 1 responds to different mechanical stresses to trigger inflammation in various tissues. The discovery of piezo 1 provides new insights for the treatment of chronic inflammatory diseases related to mechanical stress. This newly discovered ion channel shows great relevance for mechanically sensitive chronic inflammatory conditions such as knee-OA and lumbar disc degeneration. Here on the right, we see a representation of mechanical force opening up the piezo 1 channel, allowing for a calcium influx, which will lead to node-like receptor P3 assembly of inflammasome, as well as activation of the nuclear factor kappa B pathway, initiating the release of IL-1, which we all know is a pro-inflammatory cytokine. Now we have an inflammatory cascade kicking off. This also leads to upregulation of more of these piezo 1 channels and an increasingly mechanically sensitized disc. So piezo 1 on the nucleus pulposus cells, they sense mechanical stretching, induces the calcium influx, again initiating these two nuclear factor kappa B, NLRP3 inflammasome pathways, leading to the release of IL-1. Mechanical shock induces mitochondria, and the endoplasmic reticulum stress through piezo 1 begins leading to the apoptosis of the nucleus pulposus cells. Chronic inflammation and loss of nucleus pulposus cells leads to disc degeneration. Important points here. This is a study recently done where they basically demonstrated that a single impact injury of the vertebral end plates without structural disruption, meaning there was no structural damage visible, was enough to initiate disc degeneration through the piezo 1 mediated inflammation and metabolism dysfunction. So if we kind of extrapolate out and hypothesize a bit, it means we don't have to have a great impact. We just need some sort of abnormal loading event that activates this piezo 1 channel that can lead to the initiation of this inflammatory cascade, metabolic dysfunction within the disc, and then without rescue from the previously studied pro-resolution system, this process can be left to continue on and on. So piezo 1 activates nuclear factor kappa B and assembles inflammasome that initiates the release of IL-1B, which we know to be a critical cytokine in disc degeneration. The whole process is considered a positive feedback loop in which IL-1 exposure, again, leads to upregulation of the piezo 1 channel and increasing mechanical hypersensitivity and the further release of pro-inflammatory cytokines. So again, we're seeing a pathway where no injury is necessary to initiate this inflammatory cascade, and this process left to continue can lead to disc degeneration. So initiation of inflammatory cascade, we have M1 macrophages and IL-1 cytokines having three big effects. The first being degradation. We get increased matrix breakdown through the production of the matrix metalloproteinases, interfere with intervertebral disc extracellular matrix remodeling, downregulating aggrecan and collagen 2 gene expression activation. We get a recruitment of more immune cells into the disc, and then finally an induction of the neurotrophins, nerve growth factor, BDNF by disc cells and the immunocytes. Nerve growth factor and BDNF induce production of pain-associated channels, ASIC3, TRPV1, and the dorsal root ganglia. We've already discussed all the effects of nerve growth factor and BDNF on the transition to nociplastic pain. So here we have initiation of the inflammatory cascade, perhaps through this piezo 1 mechanically sensitive ion channel in the disc. Clinical note, presence of these factors in the inflammatory microenvironment of the degenerated disc is thought to promote dorsal root ganglion and dorsal horn sensitization, as we know. And now we have a clear-cut path to central sensitization and nociplastic pain, again, perhaps without any serious structural damage to the disc, simply an abnormal loading event leading to the initiation of inflammation. So the release of pro-inflammatory cytokines in the disc, which act on mast cells and macrophages to trigger secretion of nerve growth factor. Cells in the disc upregulate expression of nerve growth factor and substance P during inflammation. As we saw, painful degenerative discs seem to have upregulated nerve growth factor and substance P. Second, increased levels of nerve growth factor retrogradely transported to the DRG or stimulate mastocytes and macrophages locally, initiating a positive feedback loop. Number 3, increased levels of nerve growth factor reach the DRG, act on the TRK expressing neurons, which are the peptidergic neurons, inducing expression of peptides that mediate pain. Number 4, the increased levels of nerve growth factor in the disc, as well as the breakdown of the intervertebral disc aggregans, results in the ingrowth of nociceptive nerve fibers and presumably in anterograde transport to the IVD, which maintains pain. 5, synaptic transmission in lamina 1 and 2 of the dorsal horn of the spinal cord is mediated by substance P and CGRP. In addition, BDNF produced in the dorsal root ganglion projects to the same spinal cord laminas and modulates pain transmission. Again, how does it modulate pain transmission? Well, it works to phosphorylate and activate the NMDA receptors, and it leads to disinhibition of the inhibitory interneurons. Number 6, as discussed in Chapter 1, activation of microglia, disinhibition by BDNF and pro-inflammatory cytokines, and unmasking of the NMDA channels and potential phenotypic switching leads to late-stage central sensitization. Let's don't forget about the role that the lipid mediators play in terms of pro-inflammatory. COX-2 activation via IL-1, so Remember, the inflammatory cytokine IL-1 activates COX-2 enzyme and the nuclear factor kappa B pathway, leading to production of NO and PGE2 from arachidonic acid. They work together to inhibit the synthesis of aggrecan and the nucleus, leading to the destruction of the structure and function of the extracellular matrix. In addition, increased PGE2 level can affect the catabolic-anabolic balance in the disc, for example, by promoting the expression of matrix metalloproteinases to further accelerate disc degeneration. The breakdown of the extracellular matrix, of course, will lead to the classic hypermobility seen in degenerated disc. Our studies show that significantly more IL-6, IL-8, and PG2 are produced by disc from patients with chronic low back pain compared with disc from patients with sciatica. So again, showing a role for neuroimmunochemistry in the development of chronic low back pain. Both IL-8 and PGE2 are known to induce hyperalgesia. Can this process be interrupted or resolved? How? Well, if you've finished Module 2 and paid attention, we know, of course, it can be resolved as long as we have the ability to shift the balance from pro-inflammation to pro-resolution, which means we need the ability to polarize our non-neuronal immune cells towards a pro-resolution phenotype, and likely we need pro-resolution lipid mediators that come, of course, only through diet or supplementation. So looking at the effect of IL-10, the degeneration of intervertebral disc is a risk factor for chronic low back pain. Anti-inflammatory therapy could alleviate IVD degeneration. IL-10, as we know, an important anti-inflammatory cytokine. However, the effect of IL-10 on the intervertebral disc has not been fully revealed. This study is here to reveal the effect of IL-10 on intervertebral disc and its underlying mechanism. So they used IL-1B, again the classic pro-inflammatory cytokine in the disc, to induce the degeneration of the nucleus pulposus cells. mRNA expression level was determined by PCR. Protein expression level was determined by Western blotting. Methylene blue used to determine the expression of aggrecan, and immunocytochemical staining used to determine the expression of collagen II. A rat caudal IVD degeneration model was established and used to evaluate the effect of IL-10 on intervertebral disc in vivo. So the results: IL-10 could alleviate nucleus pulposus cell degeneration in both morphology and extracellular matrix. IL-10 could decrease the mRNA expression of IL-1, TNF-alpha, and collagen X. IL-10 could also increase the protein level of collagen II and aggrecan. Western blotting further revealed the mechanism of the positive effect of IL-10 on intervertebral disc. IL-10 reduces phosphorylation level of P38 MAPK effectively. Again, P38 MAPK, another inflammatory pathway. Rat caudal intervertebral disc degeneration model further confirmed the positive effect of IL-10 on intervertebral disc degeneration and its mechanism in vivo. So, of course, pro-resolution cytokines, one way to stop that. As well, we know the lipid mediators, so our specialized pro-resolving mediators. This study aimed to investigate the effect of omega-3 supplementation on intervertebral disc degeneration. So they found a few mechanisms whereby these SPMs could be useful to reduce degeneration. Various mechanisms may contribute to the observed effect of omega-3 supplementation on the reduction of intervertebral disc degeneration. First, the detected reduction in the serum arachidonic to EPA ratio in animals receiving omega-3 diet may result in a reduced production of arachidonic acid-generated pro-inflammatory eicosanoids. This in turn may diminish inflammatory process and therefore attenuate disc degeneration as demonstrated via micro-MRI and histological analysis. Second, enhanced production of specialized pro-resolving mediators derived from EPA and DHA may be involved in the attenuation of disc degeneration in the omega-3 fatty acid diet-treated rats. The SPMs evoke potent anti-inflammatory mechanisms involving immune cells. What we know that means is they polarize these immune cells towards a pro-resolution phenotype. We observed a more hydrated and intact disc tissue in omega-3 fatty acid diet-treated rats, indicating either an attenuated degeneration process or an enhanced repair of the damaged tissue. Finally, antioxidant effects of omega-3, as previously reported in combinatory application with vitamin E, may contribute to the observed reduction of disc degeneration, since an association between oxidative stress and disc degeneration has been shown. Conclusion: the results of this study suggest that omega-3 fatty acid dietary supplementation reduces systemic inflammation by lowering AA-EPA ratios in blood serum and has potential protective effects on the progression of spinal disc degeneration, as demonstrated by reduced needle injury-induced dehydration of intervertebral disc and reduced histological signs of disc degeneration. So, to recap, the role of neuroinflammation and dysregulated immune system in chronic low back pain. Hopefully this module has helped put the pieces together, understanding that yes, imaging is not the best way to determine a pain generator, but if a patient is in pain, especially chronic back pain, we need to start thinking less about biomechanics, more about biochemistry. And it's important to realize initiating inflammatory events in the disc is practically unavoidable and unrealistic. Mechanically sensitive ion channels in the disc, such as piezo 1, make this an impossible task. Avoiding spinal flexion, not realistic. We realize that. It's like telling someone with knee pain or knee OA not to bend their knees, just walk with their legs straight. I mean, it's silly, right? We can't do it. It's not feasible. What is important is that the person has a balanced chemistry that allows for resolution of these inevitable inflammatory events. You're not going to get through life without creating inflammation in your knees, in your spine, in your disc. What's important is that you have a lifestyle that allows for a healthy, balanced chemistry so that you can repair from these inflammatory events. So the question, if you do have a chronic low back pain patient in front of you, what has gone wrong as a whole to perpetuate these nociplastic changes? Of course, there's lots of options here. Lifestyle, excessive weight, high BMI, smoking, lack of sleep, stress, beliefs and attitudes, activity levels. Maybe they've had multiple recurrences, and with this enhanced neuroinflammatory response, we know as microglial priming, maybe eventually that neuroinflammatory response becomes unrecoverable. So we're just shifting the focus away from, of course, the biomechanical aspect of treating low back pain and realizing that when it comes to chronic back pain, the answer is likely somewhere in the neuroimmunochemistry, which currently remains invisible with our imaging like MRI and a little bit hard to investigate. So we just have to assume that there is something going wrong with this person's chemistry. So moving into the last module, module 4, we'll finally put it all together in terms of the patient's chemistry and what you can do as a clinician to guide that person back to a healthy, balanced chemistry. Thanks.